All right, so we're going to begin our discussion of EHDC 4, talking about the endocrine system. So remember, quick refresher, major glands of the endocrine system. We have our pituitary, which has an anterior and posterior component, the thyroid and parathyroid, the adrenal cortex and adrenal medulla, pancreas, ovaries, testes, thymus, and pineal gland. So one of the most important things to think about is the hypothalamus pituitary thyroid feedback system. We also have a hypothalamus pituitary adrenal feedback system as well. So you will likely find that the hypothalamus and pituitary together tend to control most other endocrine glands, either directly or indirectly. So in this case, the hypothalamus releases thyrotropin releasing hormone, which is going to stimulate the pituitary to release thyroid stimulating hormone. Thyroid stimulating hormone goes to the thyroid and causes the thyroid to create T3 and T4, which gets released into the body. Once the adequate levels of T3 and T4 have been secreted, the pituitary gland actually senses whether there's enough. So it can then continue to release more TSH, or it can slow down its release of TSH. One thing to think about is that some hormones are tropic. So like your thyrotropin hormone, your TRH, those stimulate other hormones to be secreted. And then there's other cells throughout the body that also perform endocrine-like functions, whether those cells are in organs that are thought of as endocrine organs or not. So for instance, adipose tissue, fat. Fat actually has an endocrine function. We don't primarily think of adipose tissue as being endocrine, but it does, in fact, release a hormone called leptin, and also plays a role in producing small amounts of estrogen and has all sorts of effects. So you might see things like that happening as well. So pituitary gland, as we talked about, pituitary gland is kind of the big guy when we talk about regulating the entire body. It gets along well with the hypothalamus. Typically, the hypothalamus is stimulating the pituitary gland to release stuff, and the hormones released from the pituitary gland tend to be the things that have influence over the rest of the body. So remember, we have our anterior and posterior pituitary. Our anterior pituitary, also called the adenohypophysis. Adeno, remember, is a root meaning gland, essentially. And we have our neurohypophysis as the posterior component. And this has to do with the fact that there are nerves that directly communicate with the posterior pituitary. So first thing we're going to talk about is gigantism. This is hypersecretion of growth hormone before puberty. That's the key word here for gigantism. It's before puberty, before the epiphysis of a bone has closed. So the growth plates are still open. This leads to increased bone length and produces the increased size that you see in pictures here. Typically, the anterior pituitary in this case is actually overstimulated by a tumor. So you end up getting too much growth hormone released from a tumor. And again, this happens almost all of the time. So you have to treat the tumor. One of the things you'll see here, they have what's called a transsphenoidal approach. This is the sphenoid bone right here. You go right in actually through the sphenoid sinus, and you would access the tumor growing off of the pituitary that way, removing it via the nose. Acromegaly is the cousin of gigantism, And this is oversecretion of growth hormone after growth plates have closed. So this only happens in skeletally mature people, so people that are adults. One of the big things we see with acromegaly is a stereotypical protruding forehead, as well as increased size of the jaw. Again, pituitary adenoma most likely cause. So as you can see here, this is pictures over time of an individual that has developed acromegaly over the course of 11 years. As you can see, their face starts relatively normal. You can see they've started to enlarge their nose here. We can't really get a great view of it because they've blocked off the person's eyes as kind of a identity protection type thing, but you can get a better idea of it down here in these last pictures. You'll notice that the forehead has kind of squared off. Can't see the eyebrows protruding, but there are plenty of pictures available online if you wish to see that. The big thing, though, you'll notice is going from a relatively normal jaw in the first picture to a very blocky, widened jaw and skull in the second picture. Treatment, again, you want to remove the tumor. No prevention, but the idea is you want to prevent further disfigurement from the excess growth hormone. There is increased mortality for people with this condition. They are more prone to cardiovascular and cerebrovascular diseases. Hypopituitarianism is exactly what it's named. You have a reduced functioning of the pituitary gland itself. So you could see different types of downstream effects from this. Typically, you're going to get a rather complex array of metabolic dysfunction, problems with sexual maturity, and small stature. You're going to see that thyroid stimulating hormone, or TSH, is reduced, which means that you get abnormal thyroid functioning. You get reduced corticotropin releasing hormone, which messes with the salt balance and nutrient metabolism through the adrenals. That's going to affect your balance between things like aldosterone. It's going to affect the different type of steroid productions, etc. And then gonadotropin, which is important for sexual maturity development, leading to sexual maturity during puberty. If you have a problem here, you will have impaired sexual maturity and function. It can be caused by a tumor, but there are also congenital deformities, various types of deficiencies that can also cause it as well. Treatment will be determined by the person's age. Next thing to talk about, skeletal dysplasias. One of the most common categories of these is typically commonly referred to as dwarfism, but dwarfism also has a ton of different types. What we're talking about specifically here in our endocrine chapter is dwarfism related to endocrine dysfunction. All right, not all types are caused by endocrine dysfunction, though. There does tend to be a major genetic component to this regardless, though. One of the things you'll see is a short stature and a body that's relatively small in proportion. You'll also notice that, like, one of the most common forms of dwarfism, achondroplasia, the proximal limbs, so the humerus and femur, are not as affected as the distal limbs. So you end up getting shortened distal limbs and almost normal sized proportionally to the proximal limbs. These people are also prone to issues related to the size of the foramen magnum of the skull. They're prone to basilar invagination. They're also prone to central canal stenosis in the lumbar spine. These children typically get replacement hormones and sex hormones as needed. Next, diabetes insipidus. So this is different than diabetes mellitus or mellitus, because diabetes insipidus is a disturbance of water metabolism, which is related to the hormone vasopressin. Essentially, with these people, you get extreme thirst and excessive amounts of urination. Both of those things occur in the other form of diabetes as well, but there's other problems with the other form of diabetes as well. People with a vasopressin deficiency, they do not concentrate urine very well, so their specific gravity will be exceptionally low, like lower than 1.005 a lot of the times. They're just, water goes straight through them, essentially. Thyroid gland diseases. So thyroid gland is one of the most common endocrine dysfunctions of the body. There's different types and different processes. So the first one to talk about is a goiter. This is just a term for any enlargement of the thyroid gland. It can be related to hyperplasia. It can also be related to thyroid conditions like hyper and hypothyroidism. Both of them can cause goiters for slightly different reasons. This is what a goiter looks like, and you can really see the outline of the thyroid really well right there, with the trachea kind of behind it like that. You can see it really well in this patient. My slide's not working right for some reason. All right, so generally the goiter has traditionally been related to a deficiency of iodine in the diet. And actually one of the most successful and less well-known public health initiatives ever was the adding of iodine to table salt. That's why you often see iodized salt at the supermarket. It's actually widely considered the very first true public health initiative. It was highly, highly successful. Iodine deficiency is something that we just do not see in the United States anymore. Next, Hashimoto thyroiditis. This is the autoimmune hypothyroidism. So you have all your traditional hypothyroid symptoms: cold intolerance, weight gain, fatigue, depression, mental apathy. All of these things are related to reduced metabolism because you do not create enough thyroid hormone. Heredity is a key part in this, and the patient often has a genetic predisposition. Laboratory-wise, you're going to see elevated TSH, you're going to see reduced thyroid hormone, and you're also going to find autoantibodies against thyroid peroxidase, or sometimes it's abbreviated TPO. Patients with this, you get a pretty generic thyroid replacement hormone, aptly named Synthroid, synthetic thyroid. Great name, tells you exactly what it is. It's also possible to have essentially subclinical Hashimoto's, subclinical hypothyroidism. You can have subclinical any of these conditions where you might have the autoantibodies, but your levels might still be normal. For those people, it's very important to continue to have regular testing. Graves' disease now is the most common form of hyperthyroidism. Graves is, again, another autoimmune disease. So we see symptoms related to increased metabolic activity. again, treatment here, what you actually will do is anti-thyroid hormone drugs, and there's also drugs that help block the binding of thyroid hormone. I do know people that have also undertaken radioactive iodine therapy for this. That actually kills off the thyroid, putting the person into a state of hypothyroidism. They then take synthetic thyroid hormone for the rest of their life. Next, generic hypothyroidism. Again, treated very similar to Hashimoto's. Myxedema and myxedema coma. So myxedema is a disease characterized by clinical manifestations associated with very low metabolic rate. That's why you're seeing a lot of the same symptoms here as hypothyroidism. You're going to have dry, scaly skin, puffiness in the hands and face, and the person can have the very, very severe form of this where they actually enter a coma. In this specific case, for generic myxedema, T4 is unable to be created. T4 is the precursor to T3. T3 is the active form of thyroid hormone. So you're basically seeing reduced levels of everything. Myxedema is slightly different than hypothyroidism when you look at the age that the person is more likely to develop the condition. Hypothyroidism is realistically adolescent, early adulthood diagnosis, whereas myxedema is actually a middle-aged 35 to 40-year-old diagnosis. One other thing to mention as well, now that we're moving on to hyperparathyroidism, the thyroid and parathyroid glands actually both have a key control of blood calcium. So oversecretion of parathyroid hormone, or PTH, leads to high serum calcium levels. This basically stimulates your osteoclasts to break down bone, as you can see on our diagram here. In a normal person, you really only see increased PTH secretion when there's not enough calcium available in the body. This is something that can be primary or secondary. Secondary does tend to be more common, though. One of the more common forms of this is actually related to a very specific type of lung tumor. There's also some adrenal issues, etc. With lab tests, though, you're obviously going to find increased calcium in the serum. You're also going to find calcium in the urine, which is not normal at all. And you're also going to find alkaline phosphatase is going to be elevated in these patients as well. So when you end up with hypocalcemia, because the level of PTH is too insufficient, you have hypoparathyroidism. This can also be a potentially deadly condition because it leads to hyperexcitability of the nervous system and can cause things like muscle spasms, twitching, etc. It is considered an emergency condition. Surgical destruction of the thyroid gland is the most common cause of this. Typically, if somebody has their thyroid gland removed, the surgeons do their best to remove the parathyroid glands from the posterior side of the thyroid and keep them in the body. Sometimes that doesn't work very well, especially when you're talking about something like a thyroid or other local tissue type tumor. You are better off likely just removing the parathyroid gland in those cases. But if they're not savable, then you will actually have calcium replacement therapy. Next, Cushing's. So Cushing's is a adrenal condition. You have chronic hypersecretion of cortisol levels. So these patients have thin skin, they bruise easily, they tend to have striae, which are stretch marks. Patients will have rapid weight gain, which is related to both increases in adipose tissue and water retention. They get increased blood pressure, and they get the characteristic moon face that you can see pictures of. Typically with this, there's a couple different causes of Cushing's. You see some of the big ones here related to dysfunction of the adrenals, tumors, etc. But it can also essentially be caused by someone taking corticosteroids for a long period of time. If you're taking corticosteroids for something like a autoimmune disease in order to help suppress the immune system, you are at risk for what's typically thought of as an iatrogenic Cushing syndrome. Iatrogenic meaning medical provider, medical treatment created condition. Next, Addison's disease. This is the exact opposite of Cushing's. So you do not have adrenal cortex function. These people, they develop a bronze skin. They tend to be tired, weak, agitated. They can get confused. You see all sorts of total body type symptoms. And there's also other diseases that can directly cause Addison's as well. With this condition, you're looking at blood and urine cortisol levels being very, very, very low. Sodium will be low, and fasting glucose levels are all low. Treatment is really going to depend on the cause of Addison's, but these people typically will be given replacement corticoids, specifically gluco and mineral corticoids, to help correct the salt issues that they experience. Addison's disease can be fatal, though. You can have what's called like an Addisonian crisis, and that's Addisonian or adrenal crisis, and that can result in death if not treated quickly and properly. Next, diabetes mellitus. So, diabetes mellitus revolves all around insulin. Remember, insulin is the primary storage hormone of the body for energy-containing molecules. Remember, these are fats, proteins, carbohydrates. Anytime we ingest foods that can be used to create energy, our body secretes insulin. As digestion occurs, we get an increase in our blood glucose levels. And if that blood glucose is not reduced, it's actually dangerous for the body. Glucose, despite being the primary molecule that we create ATP from, glucose is actually incredibly toxic. It's a rather ironic thing. It's incredibly toxic, especially for nerves. With these people as well, people with diabetes, it really does depend on whether it's type 1 or type 2, as we'll talk about here. But type 1 was traditionally termed childhood onset diabetes or juvenile diabetes, etc. But we have gone away from that because we're actually seeing a ridiculous number of children being diagnosed with type 2 diabetes now. Previously, type 2 diabetes was a condition for older, retired people who weren't physically active anymore and just got to do whatever they wanted all day long, eat whatever they want, etc. Nowadays, though, with modern diet and lifestyle, type 2 diabetes has exploded in prevalence. There's something like almost 40% of Americans have type 2 diabetes, and I believe it's close to 80% of Americans have at least what is termed metabolic syndrome, which is basically pre-diabetes, pre-type 2 diabetes. With type 1 diabetes, type 1 is an autoimmune process against the pancreatic beta cells. Remember the beta cells in the islets of Langerhans? They produce insulin. The alpha cells produce the glucagon. The beta cells are the only ones affected in this condition. So the body can literally not produce enough insulin. Now, for type 2 diabetes, you get this combination of cellular resistance. So what happens is insulin is made just fine by the pancreas. It makes all the insulin that it needs until one day it can't make enough because the cells have stopped responding to the signals of insulin. It's kind of like a boy who cried wolf scenario. The cells just say, you know what, I'm ignoring this signaling. And so you end up getting the extremely high toxic levels of blood glucose in the circulation, and that leads to the primary symptoms of diabetes, type 2 diabetes. So treatment. Type 1 diabetics are given insulin replacement. They have to be incredibly careful, and there are tons of different calculations that exist, especially for carbohydrate intake. Type 2 diabetics only require insulin injections if they are absolutely out of control. All right. The primary way to start treating type 2 diabetes and prediabetes is to control the diet and exercise. There are also medications that we can take that are not insulin, so sulfonylureas and meglutide drugs. These are drugs that help reduce the glycemic levels of the blood, and they help increase insulin availability and production. Metformin is slightly different than these guys, and it helps prevent the liver from producing hepatic glucose. The liver is key. You remember, glycogen, a lot of it is stored in the liver, and the liver is constantly breaking down and rebuilding glycogen. If you could stop the liver from breaking down glycogen, you can help make a major dent into the amount of glucose entering the bloodstream. So prognosis, realistically, it all depends on whether the person can adapt changes in lifestyle or not. Without changes in lifestyle, it doesn't matter what treatment someone with diabetes is being given, they will not improve. One of the major concerns to watch out for with these patients is insulin shock and a diabetic coma. If you have too much insulin in the body, so this is something we primarily worry about with type 1 diabetics, it's potentially a fatal condition if they do not use enough insulin. We also, unfortunately, have situations where individuals cannot afford their insulin, and so they try to ration it without changing the way that they eat. This leads to too high of a blood glucose level, and that essentially causes a diabetic coma. Insulin pump therapy. Insulin pumps are a newer computerized device that's combined with a blood sugar monitor to accurately release insulin levels in very small doses over 24 hours. They last longer than 24 hours, but throughout the 24 hours of the day. This can be exceptionally helpful for patients that have trouble remembering to use their insulin. And it also helps ensure that the adequate dose of insulin is being given. Again, of wanting to avoid those insulin shocks, diabetic comas, things like that. Next, gestational diabetes. So this is diabetes that starts because of pregnancy, typically between 24 and 28 weeks of gestation. Because the fetus is growing so much during this time, you see all sorts of metabolic havoc being wreaked to the mother's body. Because of that, you get gestational diabetes. It can be a major problem, but it doesn't always become a major issue. Typically, you need to monitor the mother and the fetus because it does increase the risk of complications, especially for the mother. The mother does need to watch her diet, especially simple sugars. Some oral hypoglycemic agents can be prescribed for these people. I tend to see from personal experience, though, practitioners try to rely on lifestyle modifications for gestational diabetes. So metabolic syndrome, we already talked about this. This is basically the precursor to true diabetes. You get central obesity, meaning truncal obesity. Blood pressure is elevated, abnormal triglyceride levels, abnormal cholesterol levels, and a fasting glucose level above 100 milligrams deciliter. Ideally, fasting glucose is less than 100, and realistically, ideally, it's less than 80. People with diabetes, on the other hand, they tend to have a 126 or higher fasting glucose level. You'll see abnormal triglycerides closer to 200 or higher. You get abnormal HDL and LDL cholesterol. So you'll see, HDL below 30, which is really bad. And LDL will be absolutely through the roof, with the total cholesterol likely somehow being well over 200 in these people. Another thing to watch out for is waist circumference. So if it's 35 inches or less for women or 40 inches for men, that's a positive thing. People with waist circumferences greater than those numbers are at a much, much, much higher risk of developing type 2 diabetes and cardiovascular disease. So next, hypoglycemia. We kind of mentioned this already. This can occur if there's not enough glucose levels in the blood. We've talked about it in the reference of administering too much insulin. But it can also happen if glucose is not being absorbed fast enough for tissue demands. The most likely cause of this is insulin overdose, but we can see it in people that do like extreme endurance athletic events, people who are on highly restrictive diets. They can also experience this as well. Priority, though, is to restore normal blood glucose levels. I had a friend previously who was a type 1 diabetic, and there would be times where he would slightly miscalculate the amount of food he was going to eat. He had a meal in front of him. He did a rough calculation of how much he ate, and then let's just say he ate half the food and felt full, so he stopped eating. Well, he administered his insulin based on eating the whole thing. So what does he have to do then? He actually carried around these little packets of basically pure glucose that would help him overcome that issue. Because type 1 diabetics, they do not tend to be overweight, because again, the problem isn't doesn't have the same underlying issues as type 1 diabetes. So he was actually a rather skinny guy, a very athletic dude, and he would use these pure glucose packets to help make up those levels of carbohydrates so that he didn't actually experience the issues related to potentially over-administering his insulin. Now, it was never something that he was ever truly worried about, because he still wasn't administering levels of insulin that were going to be incredibly dangerous. He still was within tolerances, but if you still administer too much insulin, you still don't necessarily feel good, right? So with people that have hypoglycemia, no matter whether it's, if there is insulin over administration, an accidental overdose of insulin, that is definitely a straight to the emergency room type thing. But if it's somebody who, they're doing an extreme level of intermittent fasting, right? They're doing a 24 to 48 hour fast. They get some of these symptoms, a little lightheaded, a little confusion, stuff like that. You get them out of it by just, a candy bar. As bad as that is for you in the long run, that is rapidly available energy for the brain. Okay, so you can get somebody out of a pretty standard hypoglycemia relatively easily. But it is important, though, to adequately control diet to prevent any of these issues. So that's everything for our week 5 discussion on the endocrine system. If you have any questions, please make sure to ask.